Alrighty. Well, good evening, afternoon, everyone. I am Ted Embry. I am a neurotologist at the University of Chicago. My pleasure to be coming to you here and kind of rounding out today's first session. We have a couple topics here that are pretty high yield. Hope to keep you on time here. I think for the sake of just moving things along, if there's any questions, I guess we can just do it via the chat at the end. I'll also be available at the otology Q&A, which I think is scheduled for the 13th of August. So the first talk is on conductive hearing loss, and we'll start by reviewing some of the acoustic properties of the sort of the middle ear system. We'll talk about common causes of conductive hearing loss and strategies for evaluation and management. And we'll finish looking at otosclerosis. That's sort of a one that we should pay a fair amount of attention to. It's pretty high yield for the boards. Talk about management as well. So I am indebted to some of the other people that have lectured on this material before, particularly my colleague here at the University of Chicago, Dr. Kluth, and the others listed here. So some of this material has been modulated and adjusted based on their prior lectures. But again, thank you to them. So middle ear mechanics, not to bore you too much here, but why do we have a middle ear? Well, because we don't live underwater anymore. So there's this air and fluid sort of mismatch. Anytime sound energy is coming from air and going to a fluid medium, the vast majority of that is going to be deflected away. So the purpose of our middle ear system is to help overcome this impedance mismatch to provide additional gain. So there are concepts of ossicular and acoustic coupling. So there's a finite amount of fluid within the inner ear that can't be compressed. And so the passage of sound energy within the cochlear duct is really the product of the difference between the sound pressure at the oval and round windows. And there's two ways that sound can get into the inner ear. So there's the ossicular coupling, which is where the vast majority of this comes in. And then there's acoustic coupling, which is the actual direct stimulation at the oval and round window. And in normal ears with an intact tympanic membrane and ossicular chain, this is typically negligible, but this may become more relevant if you're thinking about a sort of reconstructed kind of chronic ear. So this schematic just kind of, again, illustrates this, that the majority of energy is going to be coming via ossicular coupling, again, vibrating the drum and the ossicular chain, and then causing a sound pressure wave through the oval window, but again, some minimal contribution from acoustic coupling, more present diseased ears. So normally, again, you have the tympanic membrane, the ossicular chain paired with the stapes foot plate, which is going to increase sound pressure at the oval window relative to the round window, while at the same time, the round window is being shielded from everything externally, providing a further sound pressure gradient. So again, as I indicated before, acoustic coupling in particular, when the tympanic membrane is intact, is negligible. Without the tympanic membrane and ossicular chain and a diseased ear, this would become more of a factor. So not really done that much anymore, but we have different types of tympanoplasties, and there's a type 4 tympanoplasty. And in this case, what you're doing is essentially putting a large graft to kind of shield the middle ear space in a round window, and the oval window is exposed. The lack of the acoustic coupling is what's going to make the air-bone gap worse with the ossicular discontinuity versus an intact or open tympanic membrane. This is just kind of a schematic of that, but again, not typically done anymore. So what are ways that we get increased gain into the inner ear? So we will have about 25 decibels of gain, and the vast majority of this comes from the area ratio of the tympanic membrane to the oval window, and that's approximately 17:1. And that provides, again, about 20 decibels of gain, the vast majority of this. There's also the malleolo-incudal lever ratio, and that's sort of the length of the malleus versus the incus, which is about 1.3:1, and that provides a few additional decibels. And then there's the catenary effect of the malleus and some of the radial attachments of the drum, which is also a nominal few decibels. So for pathology, when we think about patients that have fluid middle ear effusions, these patients are typically going to have about a 30 decibel kind of air-bone gap. And especially if you're, considering a, reconstructed ear, saccular-plasty or, some other chronic ear, you oftentimes will have fluid, and it's you can recognize it typically from the audiogram. So no matter how well you do your OCR, the fluid can certainly get in the way. Tympanic membrane perforation, this is important. So there's obviously potential for various air-bone gaps, depending on a couple of variables. So we talk about the size, and classically we thought that, the bigger the size, the worse the hearing. So size and location honestly have a fairly minor effect, and probably one of the most important things is actually the middle ear volume. And so smaller middle ear and mastoid volumes are associated with worse hearing, with similar size perforations. And then, as I indicated before, you have the situation where if you have an intact tympanic membrane, and there's a saccular discontinuity or something like a complete stapes fixation, we'll have a maximum air-bone gap, which will be around 60 to 70 decibels. So again, there's no acicular coupling, and then you have minimal acoustic coupling because the intact tympanic membrane is blocking sound from directly stimulating the round or oval window. So moving on to causes of conductive hearing loss, broadly we can think of this kind of divided into congenital as well as acquired causes. So congenital, some of the things that we'll touch on are oral atresia, congenital cholesteatoma, acicular chain malformation. There's some associated craniofacial syndromes as well as diseases of bone metabolism. Acquired, certainly probably the most important that we see clinically is sort of chronic ear disease, eustachian tube dysfunction, cholesteatoma perforation, trauma, otosclerosis, and canal dehiscence as well. We'll kind of look at otosclerosis in particular at the end. So congenital oral atresia, this is typically unilateral, 5 to 1. It's more common in males and mostly sporadic, but can be associated with certain syndromes, in particular golden Haar or hemifacial microsomia, Treacher-Collins, Cruzone, Mobius, and Charge. So this will oftentimes come up, and it is a grading scale, so the Jarsdorfer scale. That's really how we determine if a patient is a candidate for atresioplasty, surgery to kind of reconstruct an ear canal and eardrum. So it's 10 points, and it's pretty easy. If you remember a couple of things here, that the stapes is the most important. You get 2 points for having a stapes, and then just think about a 1 point just for everything else kind of remaining. So having an oval window, an aerated middle ear cleft, normal facial nerve, a present malleus incus, and then a round window and a present auricle. So again, stapes is most important. All the other kind of things are just 1 point. And obviously, if you're considering doing surgery for an atretic ear, they should also have normal inner ear morphology and, again, preserved bone conduction. So if there's a significant sensory neural loss, you're typically not going to do atresioplasty surgery. So they would be potentially a cochlear implant candidate instead. So the Jarsdorfer score is important for helping to determine candidacy. And again, you just kind of, this is based off of a CT scan. So you kind of will look at the CT scan and go through it and kind of get a score. Scores that are higher, so 7, 8, and above, in the hand of an experienced otologist, there's about 80% chance of a good hearing result. And so that would typically be considered getting the air conduction thresholds to about 30 decibels or so. Scores that are lower than 6 or 7 are typically, we typically would recommend against atresioplasty surgery. But again, there's no hard and fast rule, but typically higher the score, better the candidate. So some other things to consider with oral atresia. So if there is bilateral oral atresia, you certainly should fit with some form of a bone conductor on a headband as soon as possible to make sure they're getting, some sound conduction to the inner ears during that critical speech and language period. There's really no need to obtain a CAT scan early, so we'll sometimes see this. The family, the patient will be, they have microtia and atresia, and they'll be the NICU, a couple months old, and they'll call you and they'll rush off and get a CT scan. There's no real need to get that until they're older. And so again, there's a lot of variability with this, but I would say most surgeons probably wouldn't consider doing any atresioplasty surgery until they're at least 5 or 6. So that's really when you would honestly just need to do the first scan. The caveat to that would be if they have maybe a partial kind of ear canal stenosis, there's a risk that for getting a canal cholesteatoma. So in that case, we would consider imaging earlier to see if there's evidence of cholesteatoma formation immediately in the canal that you can examine. Some other nuance as well. So most of these patients are going to have an associated outer ear, so some deformity, microtia. This is oftentimes coordinated with a facial plastic surgeon or plastic surgeon, and I would say that there's a couple ways that the outer ear can be reconstructed. That's typically going to be with autologous rib or something like MedPor or some other non-biologic material. If the patient and the family elect to have a repair done with these non-biologic materials, I would recommend doing the atresioplasty first. So build the canal and everything, and then have the plastic surgeon do the outer ear reconstruction later. The reason for that is if you do a non-biologic auricular reconstruction, and then the otologist goes in to try to put the canal in there, there's a very high chance that they would, as part of the surgery, expose that MedPor or whatever it is, and then that usually leads to some non-healing wound or infection, and then it has to typically be redone. So it's usually a big mess. Rib cartilage. So if the patient and the family elect for rib, usually we're going to do the atresia repair after the microtia repair. Anyway, just some nuance here, probably won't be tested. So congenital cholesteatoma, this represents a small number of overall cholesteatoma. This is going to present with a white retrotympanic mass, and classically it's going to be kind of anterior superior in the mesotympanum. And well, how does this occur? Well, we think that it's something that happens during sort of embryogenesis, some trapped epithelium, perhaps some abnormal migration of the canal ectoderm through a defect in the tympanic ring. Diagnosis typically is clinical. You would, usually carefully observe some white mass in the middle ear, kind of in that anterior quadrant. And these patients typically have no history of chronic ear disease. So they don't have a perforation, they haven't had prior ear surgery or PE tubes. And these, if caught later, they are very challenging surgery. And so very humbling for an otologist for these. If it's sort of a later diagnosis, these can be pretty much everywhere. They can really invaginate everywhere. It can be challenging to remove. But if you can catch them early when they're kind of a small isolated growth, they're actually kind of a fun case. So these are just a couple representative pictures. On the left, we see sort of intra-op kind of post-auricular approach. You can kind of see it there in the anterior superior quadrant, and this is a CT scan. You can see the soft tissue density just kind of anterior there on the promontory. So congenital ossicular abnormalities, there's a variety of these. Probably the most high yield to know about is congenital malleus fixation. And that's illustrated here on the axial CT scans. You can see there's sort of this bony bar from the head of the malleus there, which would cause fixation. So congenitally, this usually, again, is some sort of a calcification of the anterior malleolar ligament, but it can certainly be acquired as well. So patients with chronic ear disease, if there is extensive tympanosclerosis or fibrosis in the region of the attic, you can sometimes see this, with chronic ear disease. You can have erosion of the malleoinguinal joint, but that's typically uncommon. Much more common is going to be incus erosion. Clinically, on an audiogram, these patients are going to have sort of an upsloping pattern, air-bone gap that's going to be worse in the low frequencies, similar to what you'd see with the tympanic membrane perforation. And then repairing these, you can do it in a variety of ways. But typically you're going to, sometimes you can either kind of, mobilize and free up the malleus head, or potentially have to perform some form of auricular reconstruction. So incus dysfunction is much more common, and typically what you'll see is necrosis of the long process, especially with cholesteatoma. You can also see this in traumatic cases. The IS joint can become disarticulated. Repair, so ossicular chain reconstruction, you can do it in a variety of ways. If there's a diseased incus, you can potentially reconstruct it with some form of sort of artificial cement. If there's a small gap between the capitulum of the stapes, you can also use some special prostheses. You can use, just sort of a standard port and cartilage. And so when you're reconstructing these, you're missing out then potentially on the incus liver effect with a port, but that's typically minimal, maybe 2 to 5 decibels. And so this is just a sort of a transcanal example of this. You can see the asterisk there. You see the long process of the incus is absent. You can, because you're looking directly at the head of the stapes there. You can also see the round window niche inferiorly. So ossicular chain discontinuity, you're going to have an intact tympanic membrane with some form of destruction of the ossicular mechanism. And so these patients are going to have a maximum 60 to 70 decibel conductive hearing loss. There's no acoustic coupling, again, as we illustrated earlier, because the round window and oval window are blocked by the intact tympanic membrane. So oftentimes this would be caused by some form of trauma. So we'll see temporal bone fractures, and then obviously prior ear surgery. So if the patient has had some form of reconstruction and the ossicular prosthesis becomes dislodged or displaced, you can have, again, that intact tympanic membrane and then lack of coupling. On the tympanogram, classically, you'll see kind of the A subtype D tracing, so hypercompliant, which is illustrated there on the right. Tympanic membrane perforations. Classically, these patients are going to have worse hearing in the low frequencies. So in terms of some of the variables that affect the hearing, size, as well as middle ear volume. So size, so again, larger perforations will have typically larger air bone gaps. And then I think the variable that we are learning more about and maybe don't appreciate as much is sort of the middle ear volume. And so a smaller middle ear volume is going to have typically a worse associated hearing loss. Tympanoplasty surgery, that's sort of the bread and butter of what otologist does. There's, a lot of debate and controversy about the ideal mechanism or method of repair and the tissue that should be utilized. Fascia, cartilage are pretty popular. Overall, in the hands of experienced surgeons, there's not really going to be any typical difference between materials. Just do something that you can use reliably and get, good closure. And again, that typically should be over 90% or more if you're doing it regularly. So again, as I said, the audiogram will usually show a low frequency rising type pattern, as long as there's not other pathology. Obviously, if you're dealing with cholesteatoma, other things, the hearing pattern will be different. But an isolated tympanic membrane perforation, the hearing loss is going to be most pronounced in the lower frequencies. And why is that? Well, that's because of the longer wavelength of low frequency sounds. They can, in a way, sort of bend and escape back through the perforation. And so then there's less force that is being imparted on the intact remaining part of the tympanic membrane. So some congenital and other inherited problems with the stapes. So a lot that are up here on the slide, but some of the ones that we'll highlight are the X-linked CSF gusher, as well as osteogenesis imperfecta in Paget's disease. So the X-linked stapes gusher, these patients are going to often have a associated bulbous internal auditory canal and a deficient modulus that will allow egress of fluid potentially than if you're doing a stapedotomy or surgery. So again, for a young patient with a congenital suspicion for a congenital stapes fixation, I would recommend imaging to kind of rule this out. Osteogenesis imperfecta. So classically, the sort of the pathognomonic thing is the blue sclera, but this is an autosomal dominant condition, and it's related to defects of the CLL1A and 2A genes, which results in fragile bones. And there's sort of a wide variety of type of hearing loss with this. It could be purely conductive, mixed, or even sensorineural. Majority of these will have some form of stapes fixation, and they oftentimes will do still pretty well with classic stapes surgery. And this slide just kind of illustrates that classic blue sclera finding on exam. Paget's disease. So Paget's disease is a disease of abnormal sort of bone turnover and remodeling, oftentimes most involving the long bones of the axial skeleton, but can involve the middle ear and stapes. So these patients will typically have a conductive or mixed hearing loss, but sometimes it can be a pure sensorineural. And so it can cause stapes fixation because of this abnormal bony remodeling. And unlike otosclerosis, Paget's disease, the temporal bone involvement typically is more diffuse than what you would see with otosclerosis. Some other things, pathologically, there'll be multinucleated osteoclast present, and there's elevated serum alkaline phosphatase. So acquired stapes fixation, most of what we're going to deal with is otosclerosis, but this can oftentimes also occur in chronic ear disease related to sort of severe tympanosclerosis causing fixation. But otosclerosis is very high yield, so what we'll be covering here in the next few slides is important to kind of understand. So otosclerosis is autosomal dominant in about half the cases, and there's variable penetrance. There's numerous gene loci that have been identified. The prevalence in Caucasians is about 10%. 1% of those will have clinical disease. There's been some research suggesting a possible association with measles exposure. Tends to be more common in females than males, and a majority of them will oftentimes eventually be bilateral in nature, usually kind of present or peaking in the third and fourth decade of life. There's some thought that it be accelerated during pregnancy. So what is happening? So there's two phases of disease in otosclerosis. So there is the active kind of otospongiotic phase, where there's bone reabsorption, there's vascular dilation, and clinically you may see this as a short C sign. So that's something that is a pathognomonic for otosclerosis. I personally have never seen it, but maybe with continued practice, you'll see it, but it's pretty rare. The second phase of disease is more of this kind of a mature phase, the otosclerotic phase, where there's deposition of new bone, which is irregularly woven, again, more sclerotic and less dense. So what are some of the common sites of involvement? Anterior oval window region in the fistula antefenestrum is kind of the classic area where this is going to be found. Can also be seen more posteriorly. It's also can spread and be present in the round window niche. And these areas of involvement are believed to be related to some of these embryologic cartilaginous remnants called globuli interossei. But again, the fistula antefenestrum, the anterior oval window, is the most common area of involvement. So patients can get more advanced disease. So cochlear otosclerosis can affect maybe about a quarter of patients. And so what's happening with this? So for cochlear otosclerosis, there's going to be involvement and reduction in some of the cochlear function, and can affect the outer inner hair cell, spiral ganglion cells, as well as derangements with the stria vascularis. So with the stria vascularis in particular, the involvement from otosclerosis can lead to atrophy and hyalinization, and thus altering ion homeostasis within the cochlea. There's also been evidence that lytic enzyme release from the otosclerotic foci into the perilymph can cause sensorineural hearing loss as well. So we'll go through some of these temporal bone slides, which are from the very nice Massachusetts Eye and Ear Infirmary Temporal Bone Lab. And so these always seem to pop up on in-service and board exams, though obviously in clinical practice, I'm not diagnosing someone with otosclerosis looking at histopathology. So just good to kind of have an understanding of this. So this slide is kind of illustrating what I talked about, in the lateral wall here, that stria vascularis, some of the hyalinization there, wherever the arrows are pointing. And you can also then get direct deposits and erosions into the inner ear, and then the scala tympani here, the arrow indicating there, that abnormal deposit. Internal auditory canal involvement can be present as well. There's some otosclerotic bone deposition that's indicated here. You can see that density on the stain. Here's a slide indicating the again, kind of the two different phases, that kind of initial spongiotic phase here, a little bit more vascular kind of on the right, and deep to that, more of a sclerotic, dense bone. And you can see the vestibule and the adjacent sort of basal turn of the cochlea there. And here's sort of the classic photo, through the stapes superstructure and the foot plate. So you can see the anterior kind of otosclerotic bone here, and some of the thickening as well along the foot plate. And then just deep to this, you can see the saccule. So this also sometimes comes up, again, somewhat controversial, but doing stapes surgery in patients who have presumed or possible Meniere's disease. So if you think about Meniere's disease being, it's high drops, and so there's potential then for saccular dilation. So if you're making a stapedotomy or some entry through the foot plate, and you have a dilated saccule, right underneath there, there's a chance that you could pierce and rupture that, potentially cause a profound sensorineural hearing loss. And here's sort of another similar cross section that shows even more impressive involvement here bilaterally throughout sort of the anterior and posterior region, as well as the stapes superstructure itself. So evaluating and managing these patients, most of the time these are patients are going to have a normal otoscopic exam. Again, as I mentioned before, there is the Schwartz sign, which is that sort of that reddish hue that can be seen kind of in that posterior superior quadrant around the stapes foot plate. But I personally am not seeing it, so it's fairly rare. I think honestly probably even less than 10%, but that's sort of what's in the textbooks. Tuning fork, so you'll get an audiogram obviously, but most patients or most providers will oftentimes make sure the audiogram is corroborated by a tuning fork test, the RINA particularly, where bone conduction is going to be greater than air conduction. So on the audiogram, you're going to see air bone gaps, and you're going to classically see this drop in bone conduction around 2000 hertz, as you see illustrated here. You'll also, if the audiologist does it, they will do acoustic reflexes. You'll typically have absent ipsilateral and contralateral acoustic reflexes. Sometimes you may see more of a shallow kind of tracing on your tympanogram, though somewhat controversial. Most of the time they will still be fairly normal. So what is the role of imaging for otosclerosis? It's somewhat controversial. There are some surgeons that will routinely image every patient that has presumed otosclerosis. Others only get it in certain situations. I would say, these are some situations that you would want to consider imaging for. So if there is significant, sensorineural component, so if there's the bone line is quite diminished, that may suggest cochlear otosclerosis or advanced otosclerosis. So just something that may help in terms of your surgical planning. For young children, if there's been any sort of suspicion that this is congenital in nature or present since an early age, imaging would be recommended to kind of rule out an excellent gusher. Again, you would see a kind of a bulbous IAC and a deficient medialis. If there's been prior stapes surgery, so if you're doing a revision case, I would say most would get a CT scan just to kind of assess to see if there's anything about the prosthesis or displacement or other things like that, incus necrosis. If they have a history of trauma, so some history of head trauma, temporal bone fracture, or chronic ear disease as well, that's not your classic kind of otosclerosis picture. So these patients, I would certainly image beforehand. So what would you see potentially on imaging? So CAT scan may demonstrate some areas of demineralization, which is typically seen in the kind of earlier active spongiotic phase. One of these are the halo sign. We'll have a few examples of that. So that's showing active demineralization around the cochlea. Later on, you'll see less of that, it'll be more kind of dense and sclerotic. So here's just an axial cross section, kind of just indicating some of that lucency around the basal turn. And this one, probably a little bit easier to see, but you can see those kind of the halos around the cochlea bilaterally there. So how do we manage these patients? Well, there's a couple categories of treatment options. So certainly you can observe, if these patients are detected early and they have small airborne gaps, oftentimes we might recommend just observation until the hearing loss becomes more pronounced. And then they typically would have more to gain, so to speak, from having surgical correction. Medical therapy can sometimes be considered. Classically, this was fluoride. I would say more recently, bisphosphonates have kind of entered the discussion. It's still, I don't think, widely utilized, but there are some reports with not a lot of numbers, but some kind of more case reports of bisphosphonates being used to kind of potentially prevent or limit disease progression. Bisphosphonates are limiting that kind of osteoclastic driven early otospongiotic phase. Obviously, hearing amplification can be used at any point, either with traditional hearing aids or potentially a bone conduction device. And then stapes surgery, obviously, or classically a middle ear exploration with possible stapedotomy can be done. And there's, there may be some confusion about what's the difference between a stapedotomy or a stapedectomy. So a stapedectomy is typically, again, sort of removal of the entire stapes and the foot plate. I would say probably nowadays more surgeons are gravitating towards either kind of just a partial stapedectomy or partial foot plate removal, or kind of a small fenestra stapedotomy. They're just making a singular kind of small opening for a kind of a piston type implant. So surgical repair, this is, one of the probably one of the most fun surgeries that we do as ear surgeons, but stapes surgery is often, for many patients, it's preferred. They don't like the idea of having to wear a hearing aid. So the potential to have, a correctable, almost, normal hearing afterwards is very appealing. In the hands of experienced surgeons, results are typically going to be good initially as well as long term. Here are some just kind of rough indicators for when to consider stapes surgery. So there's no, hard and fast cutoff for, how big an airborne gap do you need. But I would say most surgeons would probably, feel comfortable operating if the airborne gap is about 20 decibels or so. You don't want to overlook the fact that, speech discrimination is important. So especially with kind of more advanced cochlear otosclerosis, if there's significant declines in speech discrimination, you may honestly kind of lean more towards a cochlear implant potentially as opposed to doing stapes surgery. But, you want them, if they're going to benefit more if they have good discrimination. Obviously, they have to have a willingness to accept kind of surgery and the inherent risks. And then, we talk about kind of the sort of the tuning fork test to kind of corroborate as well. So, a negative RINA in the affected ear. In terms of contraindications, so if there's any obvious active middle ear disease, that would certainly preclude surgical management. If patients have a tympanic membrane perforation, we would recommend repairing the perforation first. and then perhaps going back, some point months later. That oftentimes will come up as well. If you're doing a stapes surgery and you tear the flap and you create a perforation, what do you do? The safest thing to do is just to kind of, just do the tympanoplasty and then come back later to do the stapes. But you'll occasionally just counter like a small kind of a tear, maybe near the annulus, or just something else minor, just when you're elevating the flap. And those typically you can kind of continue on, and maybe just sometimes you don't even need the patch, or you can just put like a little piece of perichondrium or something there, and that usually takes care of it. If it is a patient's only hearing ear, again, I would say the vast majority of surgeons would not recommend operating on that, and instead have them consider amplification. If there's any, contralateral, vestibular deficit, certainly there's a chance with stapes surgery to potentially induce a transient or permanent vestibular loss. So that would be something to consider. If there's any associated inner ear malformation as well, again, in particular, like an excellent gusher. And this is also somewhat controversial, but for patients that, are doing, some sort of either, frequent, if some sort of recreation, like if they're, skydiving or scuba diving or in pilots, there's maybe been some thought to be a little bit more cautious about operating this in these patients. But I would say, honestly, most people would probably still, would say they can still safely do stapes surgery, someone that's going to be still, being a pilot or scuba diver. So stapes surgery, it certainly, you could spend, many lectures just kind of going over this, the details of stapes surgery. But a lot of this is surgeon preference. There's not a right or wrong way to do this. So it's really kind of what you're comfortable with, how you trained. So some of the things are, doing it sort of quote unquote awake with sedation versus under general anesthesia. I personally do almost all of these under general anesthesia. So especially working at an academic institution, if you're training residents and others, it's just a little bit easier to, have that, have the patient completely out. Just, sometimes things go a little bit slower, and also it's hard from an anesthesia standpoint. If you're not working with the same anesthesiologist consistently, it's kind of hard to kind of titrate these patients to be at a comfortable level throughout surgery. So obviously, many institutions, it's sort of a, rotating anesthesiologist or CRNA or resident. So you may not have that kind of continuity of care where you work with one anesthetist that is kind of, getting comfortable with these. Most of the time, you're going to be doing this through a transcanal approach. It's rare that you would ever need to do like a post-auricular approach for exposure. But some, there's also the endoral approach, which is kind of a variation type of transcanal approach typically done. It's surgeons, if they were trained, the European often training incorporates more of an endoral type approach. As I indicated before, there's sort of the nuance between a stapedectomy versus stapedotomy. So stapedotomy, sort of a small fenestra, oftentimes using sort of like a piston type prosthesis, but you can do a stapedectomy. I would say it's rare that a surgeon is doing sort of a complete foot plate removal, but some may do a partial foot plate removal. Lasers are oftentimes utilized for, these small kind of fenestra surgery where you can use lasers for vaporizing the stapedius tendon and parts of the superstructure, as well as in creating your fenestra. And then there's a variety of tissue grafts that may be utilized and different variations on the prostheses as well. But as I alluded to before, there's many different ways to skin the cat, so to speak. All of this is sort of surgeon dependent. There's not one right way to do this. And again, you're not really, I think, going to be tested on this, but it's maybe important just to know there's a lot of variation to this. And so use a technique that is most comfortable to you and gets you the best results. And this is just an intraoperative example looking at a left ear. You can see with the laser and then a little foot plate grasp, a small fenestra has been made through the oval window through the foot plate, and then you can see then this piston type prosthesis that is being crimped onto the incus there, and that's many times the crimping can be done with a laser as well. So stapes surgery, it's a lot of fun, but there's also many pitfalls and things that can go wrong along the way. So when counseling patients, you want to let them know that there is a risk of sensory or hearing loss or potentially complete deafness. And I typically quote patients that the risk of that, excuse me, is about 1% or less. Tinnitus as well. We also, discuss taste disturbance. So the chordotympany nerve, just going back to the intraoperative slide, the chordotympany nerve is often going to be kind of in your way or have to be manipulated to kind of get access to that. So many patients may have some transitory, taste disturbance. So you can see here, the suction is actually being used to kind of push the nerve out of the way temporarily while you're putting it on. In rare cases, if you need to, you can cut it, but most of the time you don't need to cut it. Infection is quite rare, but other things to worry about later would be prosthesis displacement, incus necrosis, tympanic membrane perforation. Again, that's usually something technical during the flap elevation. Again, classically, we would say if you have a big enough tear or hole, you would sort of abort and just kind of fix that and come back later to do the stapes surgery. Vertigo. So these patients will oftentimes, even if you do a very, nice, delicate surgery, they may still have transient vertigo or kind of dizziness. So I just kind of tell patients to sort of expect that. It's rare that this would persist and be something permanent. But again, you're opening up into the inner ear, or there's often going to be a little bit of perilymph leakage. So despite, your most delicate efforts, there's still going to be typically some potential to have dizziness and kind of vertigo. Things that are going to be more common in patients that have other abnormalities would be, a CSF gusher or perilymph gusher, a reparative granuloma, sort of, classically described, but typically not seen much nowadays. And that may be more related to some of the newer materials used for stapes prostheses. Facial weakness is very rare, but another pitfall potentially would be, excuse me, would be like an overhanging or dehiscent facial nerve that blocks access to the oval window. So sometimes, you can potentially manipulate the facial nerve and still do the surgery, but significant manipulation can cause potentially a transient weakness or, God forbid, permanent injury. You also have to be careful if you're lasering around the nerve as well. So what are some causes of a persistent earbone gap after surgery? So a variety of things, such as, the crimping mechanism, if the wire is a bit loose. If it is crimped too tight, it may cause sort of a delayed incus necrosis, and then the piston becomes, kind of uncoupled from the acicula chain. The piston itself can become displaced out of the stapedotomy, as indicated here on this sort of cross-section illustration. That sometimes can be a technical issue. If you measure and your piston is too short, it may have more of a propensity to kind of slide out. When we do stapes surgery, we always want to, kind of harp on the residents to palpate the entire acicula chain, make sure everything else is mobile. But if you kind of don't really pay attention to that, there may also be concomitant malleus fixation, or you potentially could miss that, which would be a cause for persistent hearing loss afterwards, as well as wrong diagnosis. So kind of wrapping up here, the final case presentation kind of goes into this a bit further. So we have a 41-year-old female that comes to your clinic complaining of a right-sided conductive hearing loss. They also have some symptoms of tinnitus and ear fullness. And so you do an exam, it's normal. You get an audiogram and you kind of see this, conductive hearing loss worse in the low frequencies. Looks like there maybe is kind of a Carhart's notch there, that drop in the bone line at 2000 hertz. So you get a normal exam. they have kind of the classic tuning fork findings that corroborate the conductive loss seen on the audiogram. And so, you're talking to the patient, you say, hey, you likely have otosclerosis. You can just observe this. We could give you a hearing aid, or we could do stapes surgery. So the patient chooses surgery. You're doing the surgery, you kind of palpate everything. You think that the stapes feel stiff, but it's really hard to tell. And you think that, well, maybe it's not as stiff as I would expect it because I was, I accidentally mobilized it a bit when I was kind of entering the ear and elevating the flap. But you continue on, you do your stapedotomy, you put the prosthesis in, you get a nice round window reflex, and you think all is good. They have a few days of kind of, just a mild vertigo, nothing out of the ordinary. It goes away. And then they come back, and then you get your audiogram, and the symptoms, it's unchanged. So still have that, hearing loss, and they still have that kind of oral fullness. So what would have been something to kind of preoperatively do to kind of help, differentiate what this actually is? So acoustic reflexes. So this case kind of harps on, something that may come up, which is differentiating otosclerosis from superior semicircular canal dehiscence. So acoustic reflexes, again, are typically going to be absent in otosclerosis because of the stapes fixation. But if the patient had normal acoustic reflexes, that would include you in that, okay, this is not otosclerosis and that there's something else going on. And then typically you would consider CT imaging to evaluate for possible canal dehiscence. So that's shown here in a kind of a perisagittal plane. You can see there's absent bone over the dome of the superior semicircular canal. So this is kind of it was only described initially in the late 1990s. So, it hasn't been around as long, so to speak. But superior canal dehiscence can cause this kind of pseudo-conductive hearing loss. So it can really kind of mimic otosclerosis on the audiogram. And what's happening is that mobile third window through the dehiscence is shunting some of that acoustic energy away. They oftentimes will have what we call supra-threshold bone conduction. So their thresholds might be 0 or -5, -10 potentially. You may or may not see a Carhart notch, but again, you're going to classically have present acoustic reflexes, and they're usually going to have a constellation of oftentimes other symptoms such as autophony, ear fullness, sound or pressure-induced vertigo, even pulsatile tinnitus. Some people may complain of like a head fog or hearing their eyeballs move. So all those things to kind of clue you in that there's something more going on than just kind of otosclerosis. Similarly, they'll typically have, the tuning forks that corroborate the hearing loss, potentially pulsatile tinnitus as well. So again, that was sort of a whirlwind tour of conductive hearing loss, but we discussed kind of the middle ear mechanics and how it's mostly there to overcome the air and fluid impedance mismatch. We discussed some of the pathologies which produce conductive hearing loss. And then we spent a lot of time here at the end kind of discussing otosclerosis, which is a very high yield topic for the boards. That's a very common type of acquired hearing loss. It's going to be a normal exam typically. There will be abnormal or absent reflexes on the affected side. Commonly will be bilateral, more common in females, and they oftentimes be a family history. Okay, so that sort of puts us there, ending on time. Let's see. So there is a question from Mickey. Would acoustic reflexes be present or absent if malleus head fixation is present without otosclerosis? So yeah, if there's any sort of fixation of the acicula chain, oftentimes you will have absent reflexes as well. All right, so I'm going to stop sharing here and get the next slide set pulled up.